Welcome everyone, and thank you so much for joining our Women's Wellness webinar. I am a GYN oncologist that covers the southern region of the hospitals that HMH covers, but primarily operate at Riverview Medical Center, and I see patients at Riverview and our new Health and Wellness Center in Eatontown. As a GYN oncologist, I see and treat women's cancers, so anything other than a breast cancer, ovarian cancer, uterine or endometrial cancer, cervical cancer, vulvar vaginal cancer, or things that might be a cancer. But one of my other interests is hereditary cancers, or people that are at risk for cancers, and that's what we'll discuss here today. Again, please, as we go along, put any questions that you have in the chat, and we will address them as we go. So here's the outline of topics that I'd like to discuss today. Some background information about genes and cancer genetics, what genetic testing is, what some of the hereditary gynecologic cancers are that I treat and see, specifically hereditary ovarian cancers, hereditary endometrial cancers, and then what we do about this. So as a little bit of background, cancer can be a genetic disease. So when this is hereditary or genetic, it's caused by changes in the genes that control the way that all of the cells in your body grow and multiply, allowing cancer cells to grow unchecked and out of control. For a little bit of science, taking you back to maybe high school biology, for people who didn't love high school biology as much as I did, maybe I'll change your minds on that today with a little bit of some science. But as you may know, cells are the building blocks of your body, and each cell has a complete copy of all of your genes. And genes are sections of DNA, which are basically instruction manuals for the cells in the bodies to make proteins or control other genes by turning them on or turning them off. There are hundreds of DNA and genetic changes. We call them mutations or pathologic variants. And these are what we're going to talk about today that allow cancer to either form or grow or even spread. These cancer-related genetic changes happen when either mistakes that are in the genes are made when these cells multiply. You can have DNA that's altered by various carcinogens, things like UV light, sunlight, and especially tanning beds, smoking, the HPV virus, or like we'll talk about today, genes that are inherited from one of our parents. So cancer itself isn't passed down through generations. It's this genetic risk from this mutation or the pathologic variant that can increase the potential to develop cancer, and that's what's inherited. We actually think that up to 10% of all cancers may be hereditary, and that the estimates are 1 in 200 people actually have a genetic mutation. So that averages out to about 25 million people, but about 90% of people are unaware of this. Not all cancers, importantly, that might be running within a family are hereditary. So we know that there's various environmental exposures that can lead to multiple cancers in a family, lung cancer, for instance, in a family that smokes in the household. So even though there might be different generations of people that have a particular cancer, not all of them are hereditary. When we talk a little bit more of some science of what is a gene for what I'm talking about today, we know, as I mentioned, each gene is made up of DNA. Scientists over the decades between the 1990s and the early 2000s did something called the Human Genome Project, and that worked to sequence all of the DNA in the entire human genome. We know after that work that we have about 20,000 to 25,000 genes, and these are what provide the map and instructions to make proteins in your body. Typically, you have 2 copies of each gene. One is inherited from each parent, so one from your maternal side and one from your paternal side. So that makes you have 46 chromosomes in each cell with 23 pairs. And most genes that they looked at in the Human Genome Project are actually the same between all people. It's only about 1% that create the differences in each unique feature, which is really amazing. Genes that we know of are given names and abbreviated labels. And so, for instance, one of the ones that we'll talk about today is BRCA1. That's the name and label abbreviation given to that gene. DNA can replicate and make copies of itself. And when it does this, it has a very strategic way that it does this. So you can see this is a picture of a strand of DNA. It's called a double helix. You can think of it as a ladder that's twisted on itself. And all DNA has the same 4 what we call base pairs. They're given letters A, T, G, and C. and they pair up the same way in every single cell. When cells divide and make copies of itself, that happens all the time in our bodies, this ladder unrotates, and each side is used to make an exact copy for the next cell. A always pairs with T, C always pairs with G. But sometimes mistakes happen. And so there are these additional pathways that exist to repair these mistakes in DNA. And sometimes they're really good, and these pathways fix all of these mistakes that happen on a daily basis. But sometimes they don't work quite as well and create mutations within that. We also have some drugs and cancer drugs that particularly take advantage of this and create abnormalities in this pathway to treat cancer. As you can see on this very busy and scientific slide, these are some of the genes that we'll talk about today, and these are what we inherited and are abnormal in how people develop a cancer. You can see here listed BRCA1, BRCA2, RAD51. These are the genes that are abnormal and prevent this pathway from working correctly. So when we're talking about what's actually mutated, this is what we're talking about on a cellular level. This is a list of the most common hereditary genes that I typically see and treat. And you can see here in the color diagram all of the variety of cancers that could be associated with various genetic mutations. For instance, at the top, BRCA1 and 2 for breast cancer, ovarian cancer, pancreatic cancer, prostate cancer. And we'll go through a lot of this today. When we specifically talk about BRCA1 and BRCA2, those are the most common hereditary breast and ovarian cancer genes that we know of. But this table also shows the average risk for women for various cancers, breast cancer, ovarian cancer, uterine cancer at the bottom, for women without a mutation. So when we're talking about ovarian cancer, we quote that risk to be about 1.3% currently in the general population. And for uterine cancer, close to about 3%. But as you can see in the first two columns of this table, if you have a BRCA1 mutation, that markedly increases your risk of ovarian cancer, for instance. And this is what we'll specifically talk about today. So how do we know people have a genetic mutation? Well, they have to undergo genetic testing. So what is genetic testing? This is a diagram that you can see of what's used by genetic counselors called a pedigree. You might remember this from some high school science classes. And this goes through all of the biological relatives that you have, both on your paternal side and your maternal side, and who, as you can see on the right, might be affected with various cancers that we fill in as sort of a black either circle for women or square for men. And this is what the genetic counselors use to work through your family history and see, are you at a hereditary risk and should genetic testing be pursued? At HMH, we have referrals to our genetic counselors. They are licensed experts in hereditary cancers and other genetic conditions, but our cancer genetic counselors see patients go through this medical history and then offer blood testing for your genetic testing, and we'll talk about that in just a minute. Some other key points. When we look at that pedigree diagram, both your maternal and your paternal history of family cancers is incredibly important. The number of people who, when I ask, are there any cancers that are in your family, only give me the maternal side for gynecologic cancers, always surprise me. So any cancers that you have, even if they are gynecologic or female cancers, but they come from your dad's side, so your paternal grandmother or a paternal aunt, those count too in family history. When we talk about these cancer-related genes, they are inherited in a pattern called autosomal dominant, meaning there's a 50-50 chance of inheriting this gene, basically the flip of a coin. And each child has the same 50-50 chance. So, one child being affected doesn't change that probability of the other children inheriting a mutation. Generally speaking, the most important person to test for a hereditary cancer is the person who actually was diagnosed with the cancer. We call that an informative result. Now, we know sometimes that's not the case. That family member may no longer be living. That doesn't mean that genetic testing is not important for each person, but that is the best person to test to get an informative result. Importantly, the national guidelines are all ovarian cancer patients, regardless of family history, should get genetic testing. Another misconception is that insurance does not cover genetic testing. That used to be the case years ago when genetic testing first came out. It was incredibly expensive. That is no longer the case. We have multiple companies that perform genetic testing. These are labs that are sent out to a company that does this genetic testing. And even for patients, for instance, that don't even have insurance, there are companies that cover genetic testing for $250 out of pocket. So that should not be a barrier to care. Insurance is not allowed to deny you insurance coverage. That's based off of state and national laws that have come into play after the rise of genetic testing. Now, you may not be able to get life insurance, or it might be very expensive, but you are no longer able to be denied health insurance as genetic testing being considered a pre-existing condition. People may also have other results that sort of look like genetic testing, but are not if they have a cancer. So many times when people have a cancer, we in the background with the pathology lab run something called somatic testing, or testing for mutations within the tumor cells themselves. Tumor cells can have mutations that are not hereditary, that are not in your genes. So someone's somatic testing results or their tumor testing results are actually entirely different from germline, what we call genetic testing results. So some people are under the misunderstanding that they actually had genetic testing, in which case what they had was tumor testing. And those are not necessarily the same results. So you can have abnormalities in the tumor that are not hereditary and present in your genetic testing. And vice versa. You can have some normal tumor testing and somatic testing, but actually do carry an abnormal gene and are at risk of hereditary cancers. So it is still recommended to have that germline or hereditary testing. The NCCN is sort of our national guidelines created for both treatment of cancer and assessment of hereditary cancer. So you can see here a very busy slide that just lists some general testing criteria, and this is what oncologists and genetic testing and genetic counselors, throughout the country use for who should get genetic testing. And you can see here there's very specific links that take us to people who have breast cancer, ovarian cancer, pancreatic cancer, prostate cancer, colorectal cancer, and very particular guidelines for who should be tested and what risk. And this is why we encourage everyone to have a referral to the genetic counselors to go through all of this in detail if people have any cancers like this listed in the family. Again, some of the things for breast cancer that I'd like to bring up particularly is a male breast cancer. That does happen. Breast cancer in men tend to be hereditary. So that's a big warning sign and a red flag for someone who has a history of a male with a breast cancer to be seen for genetic testing. So what actually is genetic testing? The formal sort of scientific word is called multi-gene panel testing or next generation sequencing. This allows us, through blood work, to sequence multiple genes simultaneously. Historically, we used to test just one or two individual genes, and now we test 84 in a panel, for instance. Now, this also may detect some other things called pathologic variants that are not necessarily identified. And as we'll talk about this in a little bit, but as we do these very comprehensive panel testing, it does test for very large number of genes. Different tests have different costs, the number of genes analyzed, different turnaround time, and then something called a variant reclassification. We'll talk about what a variant is in a minute. But all of this genetic testing should use what we call a CLIA certified lab. So that is a lab that has specific designation and certification to do appropriate genetic testing. all of the major companies that we use at HMH for our genetic testing are all CLIA certified labs. We do also recommend that if someone previously had genetic testing before approximately 2015, 2016, that you should revisit and have another consultation with a genetic counselor or your oncologist to update your genetic testing. Because now, as I mentioned, we do these very large sequencing panels and test for many more genes than we tested for previously. So sometimes we'll see people that said, oh, I was negative for BRCA1 and 2, but those may have been the only genes that were tested. And now we test for instance, 84 genes. This goes specifically, as I mentioned, through the different types of panel testing that we use. We can use these very large multi-gene panels, but we can use very cancer-specific panels as well. So it's dialed down to just the genes that we get concerned about, for instance, in an ovarian cancer. Or we can test for a very specific gene, just that gene, if we know that that is positive in a specific family. These results will often result in something called a variant of uncertain significance, or a VUS. And that is exactly what it sounds like. It's an abnormal gene, but we're not actually sure of its significance. We don't know that it's pathologic and puts you at risk of developing a cancer. We generally feel like these are not clinically actionable. We do not treat them as a true abnormal genetic testing result. And they are often reclassified eventually as more data accumulates about this specific genetic mutation. And typically when they're reclassified, they're downgraded as just a benign, what we call polymorphic variant. This is an example of what a report from your hereditary cancer testing might look like. So this is a genetic testing report, and it shows, as you can see here, that it is positive for BRCA2. It then gives the very specific detailed mutation, and then talks about some of the risks associated with it. So when I get a result and when a patient gets a result, that's what this looks like. There might be more than one gene that's even abnormal, or some occur as these variants of uncertain significance. So again, that represents something that we generally feel is benign and is actually unrelated to cancer risk. It's basically just background genetic noise. We find it about 30 to 40% of the time. So that's why we feel really strongly that having your genetic testing, for instance, with a genetic counselor who then can tie you to an oncologist or a specialist to understand what these variant of uncertain significant results are, is really important. Again, as we get more data and research, we refine the risks and sometimes reclassify what the functional impact of this gene is. Is it really pathologic? But again, we do not make decisions for any sort of risk-reducing surgery, anything different, if it is just a variant of uncertain significance. We are aware of many of the direct-to-consumer genetic testing companies that are out there. You see them advertised for your maybe holiday stocking stuffer where you and your family can have genetic testing. This is sort of using ancestry information, and it does do actual genetic testing and gives results directly to consumers. This has not been validated for any sort of clinical or medical use. It does not provide you comprehensive genetic testing. There's a lot of aspects to the science that's behind this. This is based on something called single nucleotide polymorphisms, or SNPs. In microarray testing, it misses a lot of things like these large duplications or deletions that are not detected in this. And generally, you really don't have the informed consent that the genetic counselors do as they talk you through things that you may find out with your genetic testing. Again, this does not have any clinical validity and utility, and there's really not a lot of medical oversight. So this should not replace genetic testing. Now, certainly if it comes back abnormal, you absolutely need to see a genetic counselor for actual germline testing and confirmation. But a negative direct-to-consumer test does not mean that you are not at any hereditary cancer risk. It may just have been missed because this is not the correct way to test. We also know that there is very specific ethnicity increases, specifically with BRCA. So for women who are of Ashkenazi Jewish descent, there are something called founder mutations, which are 3 specific pathologic variants that are inherited in people with this ethnicity, with about 1 in 40 people having one of these 3 founder mutations. The carrier frequency rate of this is quite high, and so it's really important to take people's ethnicity into account. And there's a lot of work that's being done to increase this awareness in the community and encourage people of Ashkenazi Jewish descent, and including some other ethnicities, Icelandic, French Canadian, Hispanic, and African American patients, to have genetic testing for these specific founder mutations. So when we specifically talk about ovarian cancer and hereditary ovarian cancer, about 20% of ovarian cancer may actually be hereditary. Ovarian cancer, as you may know, is a challenging cancer because the majority of patients are diagnosed at an advanced stage. At least 3/4 of people are a stage 3C or higher. And although we get a combination of chemotherapy and surgery, we get about 3/4 of people into a remission. About 75% of people will recur at some point, usually within the first 2 years. Interestingly, women who have, for instance, a BRCA mutation that have put them at a higher risk of ovarian cancer, although they were at a much higher risk to develop it, they actually tend to do better from a prognosis standpoint. When we talk about ovarian cancer, what we're referring to is cancer in the ovary, but also cancer in the fallopian tube, or something called primary peritoneal cancer, which is little deposits of cancer that look like ovarian cancer spread throughout the abdomen and pelvis without a discrete large ovarian mass, for instance. Again, as I talked about, ovarian cancer should always have a GYN oncologist involved in treatment. GYN oncologists are the only cancer surgeons that also give chemotherapy, although some GYN oncologists focus on surgery only, and then chemotherapy is given in collaboration with medical oncologists. The genes that we'll talk about today, specifically related to ovarian cancer, include BRCA1, BRCA2, RAD51C and D, and then some other cancer genes that are typically seen in something called Lynch syndrome, which we'll talk about when we talk about hereditary endometrial cancer or uterine cancer, but those do also have up to about a 10% risk of ovarian cancer. Again, remember the baseline population risk is about 1.3%. So when we look at those BRCA genes, that's the line at the top. The next group of genetic mutations that we talked about are the ones seen in Lynch syndrome. But you can see in the ovarian column, there are many genes that we need to take into account for your hereditary risk of ovarian cancer. When we talk about ovarian cancer, I mentioned previously fallopian tube cancer, and that's actually where we think all of these hereditary types of cancer start. So over the last several decades, there's been a really important shift in the understanding of the pathogenesis and how ovarian cancer developed. It was traditionally divided into sort of just the types under the microscope and lumped all together as a one-size-fits-all treatment. But we really know that now there are many different types under the microscope of ovarian cancer. They have different genetic components to them, molecular components to them, and come from different reasons and different precursor lesions. And this came from some really elegant science that was done by scientists looking at women who were having their fallopian tube removed because of their risk of ovarian cancer with a BRCA mutation. And they saw precancerous lesions in the fallopian tube that matched actually metastatic lesions that they found, unfortunately, at the time of diagnosis of surgery. That's actually how we have now figured out that this type of cancer starts in the end of the fallopian tube called the fimbria. And so this is a really important shift in our understanding of what ovarian cancer is and how it starts. When we talk about recommendations for women who have any of the genes in what we call the BRCA family, so BRCA1, 2, RAD51C, D, these all kind of fall under the same family of genes that act similarly in that picture I showed earlier. we know that there's a markedly increased risk of breast cancer. You're typically seen by our breast surgeons to talk about risk-reducing surgery options as well as imaging options, alternating with mammogram and MRI every 6 months. For women who have a BRCA2 mutation, you are at slightly increased risk of melanomas, so annual dermatologic exams are incredibly important. Your pancreatic cancer screening is less clear unless you also have a very strong family history of pancreatic cancer. For women that have a BRCA mutation, we have you see our surgical oncologist and GI doctors and potentially have some annual imaging and evaluation of the pancreas. But importantly, and what I'll talk about today, is the role with a GYN oncologist for managing your hereditary risk of ovarian cancer. We always recommend that a GYN oncologist be involved in evaluation when women have a hereditary cancer gene. We would talk about things of what can be done for instance, chemo prevention. That's actually done with things like birth control pills. So there's great data that we've had for decades now that actually birth control pills significantly decrease your risk of getting an ovarian cancer. And when I say ovarian cancer, what I'm meaning is fallopian tube cancer and primary peritoneal lumped all together. Although, as I mentioned, we should call them all fallopian tube cancer. So birth control pills markedly reduce ovarian cancer risk in actually all patients, even patients that don't have a hereditary risk of the cancer, but it significantly reduces the risk in women who have a BRCA pathologic variant. That risk seems to plateau after about 7 years of use. It doesn't mean that you should stop your birth control at 7 years. It just means that that risk reduction doesn't continue to really expand after that. But it's important because there's some concern that things like birth control pills may increase the risk of breast cancer slightly. We do feel like the risk reduction for your ovarian cancer risk far outweighs the risk of potentially increasing the breast cancer risk. We do see data that shows that that risk reduction actually goes across several other types of hormonal contraception, even including a progesterone-only IUD. That's something you may have heard about for women that use it for contraception. And that does also, interestingly, appear to reduce your ovarian cancer risk. The most important part about what we discuss at a visit is your surgical risk reduction. As we talked about, women may be offered for their breast cancer risk a bilateral mastectomy or removal of the breast tissue to remove your breast cancer risk. But we know that removal of both fallopian tubes and ovaries is the gold standard for markedly reducing your risk of ovarian cancer. That removal of the fallopian tubes and ovaries in premenopausal patients may also reduce their risk of breast cancer. And while for breast cancer risk, there may be excellent screening that's available, as I mentioned, with breast MRI and mammogram, we really don't have the same imaging screening available for ovarian cancer. We'll talk about that in just a minute. Surgery can also be done at the same time with our breast surgeons and our plastic surgeons if a woman is electing to have a risk-reducing mastectomy at the same time as her risk-reducing what we call salpingo-oophorectomy or bilateral salpingo-oophorectomy, BSO. And we have very clear age ranges for when this is recommended. And these age ranges exist because we know after these age range is when your risk starts to increase significantly. So we want to pick a time that's before that risk trajectory starts to go up significantly. We do know for women who have a BRCA1 mutation, who have up to about a 40% chance of getting an ovarian cancer. Again, the baseline population risk is 1.3%, so that is markedly elevated. Those women are actually at risk of an earlier onset of their ovarian cancer as well. So their timing for their risk reduction surgery is early, 35 to 40 years. For BRCA2 pathologic variants, that age range is a little bit later, 40 to 45, because that age risk is a little bit later as well. And the risk of an ovarian cancer with a BRCA2 mutation is also less compared to BRCA1. It's about 20%. Some of the other pathologic variants that I mentioned earlier, RAD51, C, D, etc., their risk-reducing surgery recommendation age is even a little bit later, about 45 to 50, because those cancers do not start as early as BRCA1 and BRCA2. We've looked, are there any lifestyle modifications that come into play? It's really less clear for some things like, we talked about the birth control pills from the breast cancer risk, but, breastfeeding, early, sort of your period starting late in a general age range. For women who are not yet ready to have their risk-reducing surgery, what do we do for, quote, surveillance? So surveillance in the true sense of the word is a test like a colonoscopy that you can undergo that identifies a precancerous lesion, like a polyp at your colonoscopy, that can be removed and intervened on so that you don't develop a cancer. Unfortunately, we have not found any surveillance options with ovarian cancer. As I mentioned, we do feel like it's really important that you consult with a GYN oncologist. And really, at this point, our national guidelines recommend an ultrasound or a tumor marker called a CA-125, which is a blood test, really only for preoperative planning purposes. There's no high-quality data to show that this is helpful in routine surveillance in the true sense of the word. As we talked about, for women who are not yet ready for their risk-reducing surgery, if they're not also actively trying to get pregnant, we can use things like birth control pills or a progesterone IUD if they're not already using those for any other general GYN reasons or their contraception. It's important to have exams frequently, to have a normal pelvic exam to make sure you're not having any symptoms that are of concern. And it's always important to at least offer a referral to our reproductive endocrinologist and infertility specialists. Those doctors, similar to people who have IVF for infertility reasons, you can also freeze eggs or embryos if you're partnered. And those frozen eggs or embryos can be tested with something called pre-implantation genetics. And though pregnancies can happen with those eggs or embryos so that you no longer pass the gene on to children. It's a very powerful thing for everybody. And it's really important that all male and female family members know that as they're considering their childbearing and their fertility. When I see someone for their counseling visit for a new diagnosis of a hereditary ovarian cancer gene, we talk about these effects on reproduction. We talk about this referral to REI. Pregnancy does not appear to increase your risk of ovarian cancer, so people should not change their pregnancy plans just based on this alone unless they choose to. We do importantly spend a lot of time talking about the risks of early surgical menopause or premature menopause. Again, as I mentioned, for women who have a BRCA1 mutation, they may be 35 years old when we take out their ovaries. Your ovaries are what make estrogen and progesterone. It's the estrogen in particular that causes menopause if you no longer have ovaries that are producing estrogen. While we recognize that we are markedly lowering people's risks of ovarian cancer, we do see that there are some real health risks associated with early surgical menopause, which we really define as less than 45 years old. Things like bone density or osteoporosis, increased risk of cardiovascular disease, cognitive changes, and then obviously menopausal symptoms, hot flashes, vaginal dryness, mood disturbances, sleep disturbances. We very importantly address to make sure that all male or female family members have what's called cascade testing, which means they also have been tested for this gene. Sometimes we know it has maybe come from a maternal side or a paternal side, but sometimes we don't have that information. And so then that means that every biologic blood relative should be tested for this specific gene. We also talk to women about the option for 2 surgeries where we just remove the fallopian tubes, since theoretically we think that that's where cancer starts, and then take out their ovaries later. That's very appropriate for women with a BRCA2 mutation who are maybe still younger, like 35, but done having children, in which case the removal of the fallopian tubes provides excellent contraception and theoretic cancer benefit. I mentioned earlier about screening. Here's a very busy slide that shows a couple of very large studies that were done internationally to try to see, can we do screening for ovarian cancer? And unfortunately, the answer is no in all of these studies. We did not improve ovarian cancer detection rates by things like just checking lab work with a CA-125 level. And that's because it is not a perfect marker for ovarian cancer. There are many other things that can elevate a CA-125 level. Smoking, your menstrual cycle, recent surgery, a COVID or flu vaccine. They tried to look at combining these CA-125 levels with other ultrasound findings. And while it maybe found a few earlier stage cancers, it actually didn't change any survival outcomes ultimately. This remains a very active area of research, but as of now, we do not feel like we have any sort of, quote, true surveillance or screening to offer for ovarian cancer. So that's why these surgical risk reduction recommendations remain. Again, we recommend removing both fallopian tubes and ovaries with the age range that are listed here. Again, we talk about who we may offer an early removal of fallopian tubes, but then delayed removal of just the ovaries. The role for hysterectomy is less clear in a hereditary ovarian cancer gene. There's maybe a very small increased risk for BRCA1 pathologic variants in some studies, but that risk is incredibly low, and it's not clear that the risks of surgery that then make this a more major surgery as opposed to more of an outpatient day surgery outweigh those cancer benefits. Unless, for instance, there's other GYN reasons, people have a huge fibroid, other reasons to undergo hysterectomy. For patients who have a pathologic variant or a genetic mutation, but they themselves have not had a cancer and are young and having their ovaries out, you can get hormone replacement therapy back. If you've had a hysterectomy, you only need the estrogen, and it's the estrogen that affects these menopausal symptoms. But you cannot take estrogen alone if you have a uterus, because that extra estrogen will cause a uterine cancer. So really important takeaway point from this. We talked already about some of the consequences of early surgical menopause, and we spent a lot of time counseling patients on this. There's really not a lot of data to show what you should do differently. We do typically recommend an earlier bone density scan as a baseline. But then once risk-reducing surgery is done from a, quote, surveillance standpoint, there's, again, as we mentioned, no lab work, no imaging that's recommended, although we do still recommend annual well woman exams with your gynecologist, including symptom assessment, a pelvic exam. You still need a pap smear if you have a cervix, because pap smears screen only for cervical cancer. Those are important to still do. Obviously, you still need routine colonoscopies. This risk does not change how frequently you should have a colonoscopy. We did already talk about how frequently you should have your mammograms and MRIs. I, again, already brought up that hormone replacement therapy is safe and actually really important. You know, there's really a pendulum shift recently, if you read in the news, about the use of hormone replacement therapy and actually probably a better safety profile than what we previously thought. This becomes a very nuanced and specific discussion for people, but a lot of the hesitation and fear of hormone replacement therapy came, about 2 decades ago after the Women's Health Initiative was published. And there's a lot of commentary and criticisms that people have about that data. It was a much older patient population that had been menopausal for many years before you started hormone replacement therapy. And that's not what we're talking about here. What we're talking about for these patients is true physiologic replacement that continues until about the average age of menopause, which in the US is about 51. Moving on to hereditary endometrial cancer. So endometrial cancer is a cancer of the lining of the uterus. You can see a picture of the uterus here on the screen. The muscle wall of the uterus is the exterior part of the uterus, and the uterine cavity where a baby grows when you're pregnant is lined by the endometrium. Endometrial cancer is our most common GYN cancer that we see and treat, and about 3 to 5% may be hereditary. Other uterine cancers are called sarcomas. Those are cancers of the muscle wall of the uterus and are not felt to be hereditary. For the non-hereditary reasons to develop endometrial cancer, again, as I mentioned, it's any extra estrogen that's stimulating the lining of the uterus without the protective effect of progesterone. Where we see that most commonly in the US is with obesity. Everybody's fat cells make estrogen. And if you no longer have enough progesterone being made by your ovaries, for instance, because you're in menopause, that's what typically causes the development of an endometrial cancer. Unfortunately, we know that there is an epidemic of obesity here in the US. So as you might imagine, the rates of endometrial cancer are rising significantly in the US. Lynch syndrome is the most common hereditary reason for an endometrial cancer. It can increase the risk of endometrial cancer to about 70%. And then, as I mentioned, about 10% risk of ovarian cancer. So it is the second most common cause of hereditary ovarian cancer. Similarly to any of the BRCA mutations, it's a autosomal dominant mutation, so a 50-50 chance of inheriting it. And again, this is a mutation in what are called your DNA mismatch repair genes. So these are genes that repair, remember those 4 letters, the A, T, C, and G? When those don't get matched up appropriately, these genes are what repair them. In addition to the risk of ovarian cancer and endometrial cancer, it most commonly is associated with a significantly increased and early age development of colon cancer. There are also some rare cancers associated with Lynch syndrome, including stomach or gastric cancer, small bowel cancers, cancers in the biliary tract, which is a tract going from the gallbladder through the liver and out, what we call upper urothelial or urologic tract cancer, so cancers inside the kidney or the ureter, which is what drains the kidney to the bladder, even some rare brain, skin, and maybe an increased risk of breast cancer. Over the last several years, we now do universal tumor testing in everyone that has an endometrial cancer for Lynch syndrome. And that's because actually endometrial cancer was the sentinel cancer in about 50% of patients and preceded someone's diagnosis of colon cancer by 11 years. So as I show here, these are the most common specific genes in Lynch syndrome that increase your risk of all of the cancers that we talked about. And as you see, the risk of endometrial cancer in the general public, about 3% versus, anywhere from 20, 30, 40, if not higher for endometrial cancer. When we talk about fixing those different DNA repair genes, these are the specific proteins that sort of fixes those DNA, and this is exactly how these cancers form. In terms of screening for Lynch syndrome, as we mentioned, a colonoscopy for your increased risk of colon cancer is really important. So you're seen by a GI doctor. You have colonoscopies every 1 to 2 years as opposed to 5 to 7 to 10 for the general population. And those colonoscopies begin very early. This has been significantly shown to reduce the risk of colon cancer and mortality, and the risk of colon cancer are also markedly increasing in the US. We think about a biopsy of the lining of the uterus just routinely, but it really hasn't necessarily improved any outcomes, but it's certainly recommended if people have any abnormal symptoms. For instance, abnormal uterine bleeding or any vaginal bleeding. That's the most common symptom of an endometrial cancer. Any amount of bleeding counts, even just a little bit of pink on a toilet tissue with wiping. We already talked about the role for pelvic ultrasound in ovarian cancer surveillance, which is not really helpful. And it's not necessarily helpful from a uterine cancer standpoint either. What is helpful is risk-reducing surgery. Again, similar to in women who have a BRCA1 mutation, but obviously this scenario includes both a hysterectomy and removal of the fallopian tubes and ovaries. Generally speaking, the role for birth control pills will certainly help for the ovarian cancer risk, and generally is felt to decrease the risk of endometrial cancer because you have the protective effect of the progesterone. Even though you're giving estrogen, it is helpful. But we don't have great data specific to women who have Lynch syndrome. So we do strongly recommend the role for risk-reducing surgery. Now, this hasn't really been shown to decrease the overall mortality, but that's because the good news is compared to ovarian cancer, which tends to present at a very late stage with a poor prognosis, The majority of endometrial cancer presents at a very early stage, typically with an excellent prognosis and very good survival, well over 95% if diagnosed at an early stage. The role for risk-reducing surgery with a hysterectomy and removal of the fallopian tubes and ovaries is typically done minimally invasively. I do these robotically with our Da Vinci robot. You can do them laparoscopically as well. The great news is that many times we have excellent data to support that even same-day surgery is possible. And this is really where minimally invasive surgery has revolutionized surgery for GYN surgery and cancers in particular. Minimally invasive surgery took what we used to use a huge abdominal incision. Now you have 5 tiny incisions about the size of my thumbnail at the biggest. And the amount of pain that people experience is markedly lower. Importantly, the amount of narcotics that people need is significantly lower. I have many patients that are fine with just Tylenol and ibuprofen or Motrin alone after a major surgery done minimally invasively. Many of us, again, feel strongly that this surgery should be performed by a gynecologic oncologist, because the first thing I do is take a good look around. I make sure there's no visible cancer, nothing that looks concerning. And as a cancer surgeon, we're the best people to know what that specifically looks like. Here in New Jersey and in the general tri-state area, we are, very blessed to have many GYN oncologists. However, we do recognize that there are some states, North Dakota in particular. I have a friend who flies there twice a month from Colorado to see patients. But here, there's no lack of GYN oncologists, so there's no reason you shouldn't see me for this diagnosis and this surgery. Happy to take any questions. I trained at Penn for my residency fellowship, was faculty there for about 7 years, and this is a sculpture that hangs in the ceiling of the Perlman Center, which is where our cancer patients, and this is 960 pounds, and it is an accurate description of the BRCA2 gene. Again, happy to take any questions, and that is my main office number to schedule visits with me.
Okay, there are a few questions. Thank you for putting your questions in the Q&A. And again, for those that may have joined late, just want to let you know that there is a Q&A button at the bottom of the screen, and we are going to begin answering some of your questions. So one, how can ovarian cancer be found early? Are there any symptoms or signs that we should be looking for?
That's a great question. So, again, as I mentioned, unfortunately, from an imaging or a blood work standpoint, we don't have a great way for early detection. Symptoms that are concerning for an ovarian cancer are symptoms that persist and don't go away or get worse. So bloating, new changes to your bowels or bladder, new abdominal pain, new chest pain, new shortness of breath, back pain. Now, many people have constipation. Many people get bloated after they're eating, and not all of those people have ovarian cancer. But this is where we want to take this opportunity to have people aware of the very vague symptoms of ovarian cancer. And if something is not getting better or is certainly getting worse, you need to see your doctor, you need imaging, and you need to see a GYN oncologist.
The next question is women's colorectal health, screening for breast cancer, stroke treatment. Oh, I don't think that's a full question. So do you still HRT? I don't know if they mean hurt if the person had a hysterectomy, but ovaries are still intact.
Yeah, so if you are premenopausal, meaning your ovaries are still functioning, you typically don't need hormone replacement therapy until after menopause. There may be some perimenopausal changes for which hormone replacement therapy may help. These kinds of discussions are, from if it's not because of a uterine cancer that you had, those are discussions that are had best with your gynecologist. There are gynecologists who specifically specialize in menopause. You can look up on www.menopause.org is our National Menopause Society, and that's where physicians have identified themselves as having additional training and certification in menopause care. So I'll often collaborate with people's gynecologists, especially if they have an interest in menopause management, to sort of clear people from a cancer standpoint if we feel like it's safe and acceptable for them to have hormone replacement therapy, and then that continues to be managed and titrated by your regular gynecologist.
The next question is, how often should women see younger than 65-year-old get a pap smear, and then vice versa?
Yep, great question. So again, pap smear screen for cervical cancer, which we can do a whole separate webinar about cervical cancer and pap smear and the HPV virus. So cervical cancers are typically not hereditary. Those predominantly come from the HPV virus, which pretty much everyone, if you've been sexually active, has exposure to. That's actually why we stopped doing pap smears for women under 21, because most people have an exposure, but then many people clear or suppress it. But it's kind of like when people used to get the chicken pox when they were younger and then can have shingles flares later in life. People can have flares of their HPV virus, and then that can cause changes in the cervix, in the vagina, the vulva. Men can have penile cancer, anal cancer in men and women, and actually head and neck cancer. Right now, pap smears are the only thing that we have to screen for any of these HPV-related cancers. The pap smear now is actually done with a pap smear with an HPV test called a co-test, or sometimes actually primary HPV screening alone, because we know that that actually is sort of the more informative test, the magic 8-ball, if you will, of who's at a higher risk. If your HPV testing is negative, your risk of actually having a precancer cancer is quite low. There have been various changes to the frequency of when you should have your cervical cancer screening, but that is separate from your annual exams with your gynecologist. You should still have annual routine exams with a gynecologist, regardless of if you're due for a pap smear. There's many other things that are picked up or evaluated at that time. Any symptoms, masses, new lesions on the vulva, in the vagina, etc. If you have never had abnormal pap smears in your life, you have no new sexual partners, and your current partner has no new partners, which may or may not be known, then your pap smear with your HPV test screening can actually space out to up to every 5 years. But there are certainly people who either qualify or still do screening at more frequent intervals than that. Obviously, again, any symptoms that you were to ever have, bleeding, abnormal discharge, even just a little bit of bleeding, like even just a little bit of spotting, should always see your gynecologist. Most bleeding after menopause is not a cancer, but your gynecologist will work that up to see if you need to be sent to a gynecologic oncologist like me to evaluate things further for either a precancer or a cancer.
And the last question is, should I see a urogynecologist if I have pelvic floor collapse?
Yes, you absolutely should. So a urogynecologist is a subspecialty trained OBGYN similar to me. So we all have done a 4-year OBGYN residency and then typically 3 extra years of subspecialty training. I did 3 extra years of cancer surgery for my fellowship, and a urogynecologist has done extra training in sort of pelvic floor reconstruction. You can also specialize in urogynecology coming out of a urology training as well. But prolapse or loss of support, which can lead to things like urinary leakage, even fecal incontinence, is really important and should see a urogynecologist. Now, the question that I get as a cancer surgeon when I'm seeing patients for their cancer surgery discussing hysterectomy is, is the hysterectomy going to cause prolapse? That's not necessarily the case. Most prolapse, the biggest risk is actually age. Prolapse becomes much more common as we age because you just lose that support of your pelvic floor, which is basically a bowl of muscles in the pelvis. But certainly, I don't think we talk enough about people's incontinence, pelvic floor prolapse, etc. In fact, we often do combined surgeries. So I will do a surgery with my urogynecologic colleagues, and I may be doing their cancer surgery and they may be fixing someone's prolapse at the same time. So we should always address that when we can.